Thank you very much. Thank you for the audience who've stayed behind. It's not advancing. Can you advance it there? Thank you. So I think this is something that we dread seeing in our diabetic practice. I'm a general physician, but I have, at last count, more than 8,000 diabetics under my care. And of course, you do see the DKAs recurrent. And then, of course, these type of neglected patients where they might have been to a general practitioner that attempted to do something, and you get this neglected diabetic foot. So a simplified pathway is just to look at poorly controlled diabetes, that neuropathy that develops intrinsic foot muscles result in deformities, wrong footwear, wrong environment, and eventually ulcer formation. And if you look at it, all of them really is associated with pressure areas. So you get an area where there's a deformity that develops because of the intrinsic foot muscles that is imbalanced. It can be hammer toes. You can have the rocker bottom foot. You can have any kind of pressure areas that precipitate the development of an ulcer. The callus formation then develops subcutaneous hemorrhage. There's breakdown of the skin, and then a deep foot infection, often with osteomyelitis. And I think this is really where, if you look at that first picture we saw, what we see on the picture is really the tip of the iceberg. This is going to develop into a disaster on all these areas, and you can see the poor nail care on this patient. Rocker bottom foot, you can see the deformity on the foot. I should have called this the horrible slide session. But yeah, again, very importantly, that 15% of these non-healing ulcers will land up in amputation. And we know that the 5-year prognosis for these patients is even worse than for cancer. So that they really do have severe vascular disease. And the reason why they don't heal is because there's poor angiogenesis in that area. You have an inadequate expression of growth factors, so there's poor healing. There's excessive cytokine release at the area, poor epithelial migration and proliferation, and then a defective insulin action in the skin. So all of these is like a perfect storm to develop chronic disease in that foot. We have different types of neuropathy, but of course, this is the peripheral neuropathy, often motor and sensory, that affect the patient, that then go on to these complications. It is important, both from the DCCT as well as the UK PDS trials, although they didn't specifically look at microvascular endpoints in the UK PDS, that the early management and early aggressive management with glucose control had a legacy effect, which then ended up in preventing these complications in the long run. So that early treatment is important. We often see patients where nobody has bothered to take their shoes off and examine their feet. Of course, these are critical aspects. Simple test, a monofilament test, is a simple way to determine if there's early sensory abnormalities. More complex when you're looking at how the patient can sense the vibration, the reflexes, but just clinical examination is important. If we look at the neuropathic pain management, there are various agents that do help. The most important is to prevent these. By the time you do have pain developing in these patients, you've already lost quite a bit of traction in avoiding complications in the long run. Proper foot care. I always say to patients, if you can't see past your stomach, put a mirror on the ground, look at your foot that way, or get somebody to help you to look at your foot. Make sure that you inspect your toes. Look if there's dry skin. You can moisturize the skin to avoid the areas of pressure. Comfortable shoes. Daily inspection and cleaning, I think, is so important, especially in an area where people may have a situation where they work with safety boots at work, or where they have a lot of moisture on their feet. Dry, scaly skin can be treated, again, with a moisturizing agent. If we look at brittle toenails, again, a good toe preventative care is really the way to do it. And then this kind of presentation, the tip of the iceberg, it's what's going on underneath in that foot that is important. I just want to mention osteoporosis because, again, sorry, that disappeared. There may be in that patient's foot then poor bone healing. And this, again, can, apart from osteoporosis generally, which can occur in the diabetic patient, can also affect the healing in that area. Vascular examination is critical. If you do have the availability to do an ankle brachial index, but even just feeling pulses, feel if the foot is sweaty, is it dry, is there hair loss, especially of the toes and the lower part of the leg, because that may indicate that there's vascular impairment. So it is important, although neurological impairment is a very important aspect of how this develops, of course, there's a risk of vascular impairment as well. And not to be missed, because the diabetic patient is so at risk of vascular complications. If we look at arterial ulcers, again, these can go on to develop digit loss. And if you look at gangrene, this can be embolic or ischemic. And again, you know, we do still see patients that present like this. Unfortunately, they've been missed somewhere. You've got to look at cardiac causes, but then also to see if there's vascular impairment and what is reversible or not. And we have seen some of these that present quite late can be improved if you treat them with appropriate angioplasty or vascular reconstruction. But again, it depends, especially in a diabetic patient, it's usually the small vessels, and they're not obviously amenable to interventions as would be bigger blood vessels. So it is important in these patients that, again, antiplatelet agents may become important, but preventative is actually much more better than trying to come in afterwards. So you've got to look for arrhythmias, look at other vascular beds. What about the carotid arteries? Is there evidence of coronary artery disease? And remember in the diabetic patient that these may be silent. I recently had a patient just presenting with some fatigue symptoms, and her ECG had changed over the last year. Now she had a resting tachycardia and nothing else. She had no chest pain. And when we did a coronary angiogram, she had triple vessel disease and she needed a bypass. So it's always important in our diabetic patient to just be aware of the other vascular beds. We've heard about stroke, and of course the patient with diabetes is particularly at risk of ischemic stroke with complications with accelerated cardiovascular disease. Don't forget about venous disease. Again, venous ulcerations and the complications that go with it. Often in the obese patients, this may be a problem. And preventative in this situation, you may just need to use elastic stockings. Weight loss obviously is important. And we do have these agents available now, although I believe that most of the obesity drugs have been abused in America. So we are lacking them in many countries. But again, you know, I think they have made a big difference in our management of obesity per se. But of course, not to forget about venous disease in our diabetic patient. It is important, if there is sepsis present, that you do adequate debridement. It's very good to have a surgeon that work with you if you are seeing these patients, because it's not just a question of treating the patient medically. Obviously, with antibiotics, depending on the organism, a tissue biopsy is important. Blood tests will not show you. CRP may be completely normal. But if you can get the surgeon to do a tissue biopsy to see what the organisms are in that area, that might help you to decide about antibiotics. And sometimes you need prolonged antibiotics to treat these patients adequately. Offloading the pressure area. So total contact casts may be necessary. They've used moon boots in this situation to try and avoid the pressure on the area. And then the role of MRI, because oftentimes these patients have deep sepsis in the muscle and in the tendon sheath that may not be visible on ultrasound. So that MRI of that affected foot may really give you a lot more information, and then can also inform the surgical debridement that might be necessary. Then, of course, looking at the vascular supply and managing the patient from there. Poor wound healing, as I've mentioned, there are many factors that affect it. But again, that hyperglycemia with oxidative stress is the most important, and that really just worsens the patient's ability to treat the condition. There are ways with your podiatry unit to look at pressure areas. There's even a foot pad that will show up hot areas on the foot that may be at risk of developing a callus and then progress from there onto ulcer formation. We have orthotics, and different orthotics, again, one has to be careful that these don't cause pressure themselves, and to make sure that your podiatrist is well aware of monitoring. And I think it's really just seeing these patients in follow-up and seeing whether the intervention is making a difference or not, to avoid complications. I think the uglier, the better. So I do see these ladies with these very beautiful shoes, but your diabetic patient, no, not a good idea. You need the broader shoe. I'm not saying we should all walk around with these, but again, it's just the principles, and to try and get the patient to understand how important it is to prevent this from complicating. This is just a cartoon to show the various factors that may be affecting the person: motor neuropathy, sensory neuropathy, and autonomic neuropathy, decreased sweating with a dry skin. Alternatively, there can be excessive sweating and a risk of making that foot then prone to infections. It is important to look at the peripheral arterial disease, repetitive trauma, and then the subcutaneous hemorrhage and foot ulcers that may develop. So just to be careful at the time when the ulcer is there, you've already missed the boat. Just as far as management is concerned, the STENO2 study did show, again, this legacy effect. This was the initial study that showed intensive therapy, multifactorial, both glucose control, yes. Blood pressure control, yes. Lipid therapy, like we discussed before. Stopping smoking. And these patients showed in the follow-up that that early intervention was maintained also even 13 years after the initial intervention had started. So that legacy effect of good risk factor control on all aspects is really the best way to avoid the diabetic foot complications. Thank you very much.